Hello and welcome to Live Healthy West Virginia, the podcast brought to you by WVU Medicine, aiming to help everyone live a better, healthier life in West Virginia and beyond. I'm your host, Mary Ravazio Menard. It's estimated about 117,000 women in the U.S. will be diagnosed with gynecologic cancer this year, and about 34,000 will die from their condition. This group of cancers includes those affecting the cervix, ovaries, uterus, vagina, and vulva. It's National Gynecologic Cancer Awareness Month, so we're talking about the risk factors, prevention, and treatment of these cancers of the reproductive organs with Dr. Wade Barton, a gynecologic oncologist with the WVU Cancer Institute. Welcome, Dr. Barton, to Live Healthy West Virginia.
Awesome. I'm so excited to be here today and to talk with you.
Well, it's great to have you here. It really is.
Thank you.
Now, we mentioned that you're a gynecologic oncologist,
Yes,
so I
ma'am.
want to start there because I don't think a lot of people know what a gynecologic oncologist is.
I was going to say, I didn't know what one was even through medical school until probably my very last year and was like, I think I want to do this. So as a gynecologic oncologist, I only take care of women. I have not taken care of men in over a decade and have come to terms with that. And I'm kind of fine with it in some respects. But as me specifically, I only deal with cancers of the female reproductive tract. So your uterus, your cervix, your fallopian tubes, your ovaries, and then the vagina and the vulva. We are a unique specialty in that we do chemotherapy and surgery simultaneously, whereas a lot of the other cancer specialties will either just do surgery or just do chemotherapy. But we are kind of, because there's not that many of us, and this is such a subspecialized field, that we kind of do everything and then ask for help along the way.
So it sounds like you're a surgeon, a gynecologist, and a cancer doctor.
A cancer doctor. And at one point I used to deliver babies, but I don't do that anymore.
Okay. Well, you said it was a very specialized subspecialty. Yeah.
Yes, ma'am.
So there are several kinds of gynecologic cancers, but let's start with what are the big four, the most common.
The most common ones.
Yeah.
So I think the good news is that GYN cancers in and of themselves are rarer than other types of cancer. So that's good.
Yeah.
I think within that, us specifically, endometrial or uterine cancer is probably the most common. And then ovary cancer, cervical cancer, and then vaginal and vulvar cancer are kind of the most common ones that we would see during a week in our clinical practice.
Those are the typical ones you
Yes, ma'am.
see. Yeah. And I'm assuming, as with all cancers, early detection is best. So let's talk a little bit about, what the screening guidelines are for these cancers.
So I think this is why our subspecialty exists, because for most of the cancers we see, there aren't screening guidelines.
Okay.
I know breast cancer is kind of the cancer that we compare ourselves to the most frequently. And breast cancer has excellent screening guidelines with mammograms and follow-up and lumpectomies. But for us, we can't screen for a majority of our cancers. So ovary cancer, there's actually not screening guidelines unless you have a specific genetic condition that increases your chance to have that. For endometrial cancer, again, no screening guidelines unless you have a specific genetic condition. The good news is there's probably the ones that are the hardest to treat. So cervical cancer, there actually are screening guidelines, and that's a pap smear. And that's why we kind of harp on people to get pap smears at the frequency they need to prevent cervical cancer from happening.
Okay. Good to know. So then what are the referral parameters?
I think a lot of the times our typical patients will have had an issue for multiple years because they're off living their lives, taking care of their children, their grandchildren, their husband, and eventually say, I'm having something that's just not normal, that's not going away. And so they'll see their primary care doctor. And usually the biggest complaint we get with all of our cancers is vaginal bleeding. So either super heavy bleeding that doesn't stop or bleeding after someone's gone through menopause. When someone has that type of bleeding and is able to see a provider, most of the times they get immediately referred to us, where we kind of complete the workup and then make a treatment plan moving forward.
Okay, so that kind of vaginal bleeding is never normal.
If you've gone through menopause, you should never, ever have vaginal bleeding. I hate to say ever again, because that's like a always statement, but you should never have vaginal bleeding after menopause and not have it worked up. Because it's just highly abnormal and is the most common symptom of a lot of the cancers that we see.
Okay, good to know. What are the risk factors of these cancers?
I think even though I take care of all of them, they all behave very differently and all have very different risk factors. For ovary cancer, the biggest risk factor is a family member who's had it, because there's usually some genetic component to that. But otherwise, there's really not any risk factors for ovary cancer. For endometrial cancer, the biggest risk factor is obesity, which is an epidemic, pandemic. It's everywhere. And so as we see more obesity, we're also seeing more endometrial cancer, even in our younger patients. So like our late teens, early 20s, just because of our diet and the way that we live. But that's the biggest risk factor for that. And then cervical cancer and vulvar cancer, the biggest risk factor is HPV. So the HPV virus, that's the cause of 99% of these cancers.
Tell us a little bit about what is the HPV virus?
So the HPV virus, if you were to look it up on Google, it would be classified as a sexually transmitted infection, which we never call it that because there's a lot of stigma behind that terminology. HPV is a virus that if you've ever had intercourse one time, there's a 90% chance that you have HPV. So almost everyone universally has HPV. Women, unfortunately, are the only ones we test for HPV. So women kind of get burdened with the stigma and the diagnosis of having HPV. Whereas men, we don't test them unless there's a reason to. So men kind of get off free, even though they're probably the cause of the majority of HPV.
They always do.
Always. It's always men. Always men. Always men. But we know that HPV for cervical cancer specifically is the cause of 99 out of 100 cases. And it is unfortunate because there's a vaccine, the HPV vaccine, that can actually prevent cervical cancer. It can help prevent vulvar cancer. It can help prevent rectal cancer and then head and neck cancers. And it's just countries who've increased the prevalence of HPV vaccination have seen dramatic decreases in cervical cancer, where there's some European countries that don't see cervical cancer anymore, like at all, because their school children are vaccinated against HPV.
What if you're too old for the HPV vaccine?
I was gonna say it probably 10 years ago, I would have been too old for it. And I think I'm like super young and happy. But within the last decade, the FDA has actually said you can be up to 45 and be vaccinated for HPV. So that's men and women. So, half of the world theoretically meets those criteria for HPV vaccination.
Okay. Well, it's good to know that too. And I'm just going to assume that GYN cancers, does your risk increase with age? It
does. I would say it's not an always statement, but the longer someone's alive, the more likely they are to have something happen to them, or to get some sort of condition that increases the chance of developing something. I would say for endometrial or uterine cancer and ovary cancer, our typical patients 55, 60, postmenopausal. We are unique in that our cervical cancer patients, though, can be as young as 21 and usually are late 20s, early 30s, just because that's the person who's had HPV kind of the longest in that part of their life. It hasn't had access to medical care, and it's kind of like a perfect storm. But in general, our patients are usually postmenopausal.
Okay. There are more options for treatment for these cancers. So I want you to talk about the latest, greatest treatments.
Groundbreaking news.
Yeah.
I think as a surgeon, my first treatment is always, let's do surgery. Let's take you to the operating room. Let's cut everything out. That's not the latest, greatest breaking treatment, though. That's been around forever, I would imagine. And so we've realized as a subspecialty that maybe doing surgery isn't the best thing to give our patients the best outcomes possible. And so that's why we started to use a lot more chemotherapy. But chemotherapy also has a bad reputation, deservedly so, because of the hair loss, the nausea, the vomiting, the fatigue. No one wants to take chemotherapy. And so we have started to develop a lot newer drugs that are specialized and personalized to a patient and their tumor. So you don't get the side effects, but you get the same, if not a better benefit with these newer medications.
So it's much more focused.
Very, very.
Now, is this immunotherapy?
It is. Immunotherapy. The biggest drug that we use is Keytruda or pembrolizumab. There's too many syllables in that, so we just call it Keytruda. The body in and of itself is a remarkable organism. And so when someone has cancer, the body kind of sends off alarm signals and says, this is abnormal. We need to try to kill this and get rid of it. But cancer is smarter than us a lot of the times and will kind of wall itself off or build itself like a bomb shelter. So no matter what our body does, it's unable to naturally fight the cancer that we have. And so these newer drugs that are targeted kind of drill holes in the bomb shelter or open the locked door and let our immune system back inside the tumor to actually kill it with our own body's ability and capabilities. And so it uses you as the treatment, which is a remarkable kind of, practice-changing medication treatment for us.
Is that considered a cure, or at least very close to one?
I would say we don't often use the C word.
Yeah.
But a lot of these immunotherapies have allowed us to say we are going to give you as close to a cure as possible. And even in patients that maybe not have been curable 5, 10, 15 years ago, we are seeing people live for 5, 6, 7 years without symptoms on these drugs before we even have to talk about a second line therapy or a second treatment, which again is remarkable even within the last decade for our subspecialty. And
this obviously gives us a lot of hope. It has to be impacting survival rates, right?
It does. I would say, probably 2-3 decades ago when people got certain cancers like ours, it was a death sentence,
Yeah.
And that's why a lot of research and energy and time has gone into figuring out how can we have better outcomes for half of the population that are women. And so these drugs now are either helping us cure people up front, so at the very start of their disease journey, or keep them in remission for as long as possible before we have to talk about a second treatment. And so people are living remarkably longer, but I think in a different vein, they're living happy, productive lives. So they're able to go to work, go to church, go to picnics, go spend time with their family, and still be cancer-free and in remission.
So you're extending not just life, but quality
of life. Which is honestly, when you get into the throes of cancer treatment, people want to live a quality life. And so to be able to provide that for patients it makes you feel good at the end of the day.
And these aren't the only new treatments, right? I mean, there's like an explosion going on, isn't there?
I hate to say a gazillion, because I don't know if that's even a real number, but it seems like there's a new one every week. I just finished fellowship, and so every, honestly, 1 to 2 weeks, we'd get a new paper, a New England Journal of Medicine. We'd have a new pharmacist come talk with us about a new drug. We'd have a new oncologist from a different specialty come and talk with us about a drug. And I would say everyone thinks their specialty is the best. So obviously, I think my specialty is the best. But I think as far as research potential and where we're going, we have seen an explosion in beneficial, useful drugs in our subspecialty that are giving patients opportunities to live longer and, like I said, just better lives.
Wow, that's really exciting.
It is. And I don't think a lot of times medicine, you get to say that to patients, like, I'm going to give you something that may give you a better quality of life. But I'm able to say that, I'd say, pretty routinely to people.
That's excellent. That's excellent. What are the treatment options? You mentioned a little bit about chemotherapy. What other treatments are there besides chemotherapy?
I think the thing that makes our subspecialty, again, unique is that we want to do everything, but have come to realize that we are unable and probably not the best people to do everything. And so we kind of say, we're your point person, we're your coach, but we're going to have to call in some, I don't do sports, sub coaches, extra people, helpers.
That works.
Yeah, other people, other experts to help us. And so a lot of times we rely pretty heavily on our radiation oncologist or our radiation doctors to help shrink tumors down so that we can do surgery or shrink them down and cure them. We rely really heavily on our medical oncologists, so doctors that subspecialize in chemotherapy administration, because they're this is their life or the drug therapy part of cancer. We also rely on our pharmacist. our nurse navigators to do the chemo teaching. It's like a colony of people when you get into the cancer center. And I don't think people realize that it's not just me. I'm not just your doctor. I'm your coach, but I have a whole group of people behind me helping treat you and get you to where you need to be.
It really is a team sport.
It is.
The treatment.
Very.
Excellent. So let's talk briefly. We mentioned the big four.
Mm-hmm.
So let's talk a little bit about each of the big four. Mostly, everybody wants to know about symptoms and things. So let's start with uterine or endometrial cancer.
Mm-hmm.
This has a pretty high early detection rate, doesn't it?
It does. I have always told patients, if you have to be unlucky enough to get a cancer that you have to see me for, I would always want an early stage uterine cancer because people have symptoms. So most of the time, people have not had any vaginal bleeding or any periods for 5, 6, 7 years. And then all of a sudden start to have not even regular cycles, just like unpredictable vaginal bleeding.
No.
And most people have celebrated not having a period and now they're bleeding again and they're like, why? This is not normal. And so it prompts a doctor's visit and then they end up with me. For early stage uterine cancer, we can do surgery. And I would say cure 9 out of 10 people. And like, I use the C word as a cure because I like
said
really,
cure.
I know, I saw it, but we like truly mean cure with this because we can do surgery, remove it, and then call it a day.
That's very exciting.
It is. I always hate to see new endometrial cancer patients because they have cancer, but it's always nice to know that I can reliably say you have the best chance for a cure with this surgery and like truly mean it.
And most of the surgeries are minimally invasive.
Minimally invasive. So tell
us exactly what's the definition here in this case?
So I think most people, when they think of surgery, think a big up and down incision from like, here to here, or they think a side to side that a baby's born through. We do those surgeries, but they require 3 to 4 nights in the hospital. They're 4 to 6 weeks of healing. They're really hard to recover from. And so we've learned within the last 15 to 20 years to do things through tiny, small incisions. So incisions the size of my thumb across your belly, where we operate outside of the body. So we use a robot most commonly that we control to help take out everything so that you don't have a giant incision. Patients go home the same day for the most part. They are back to their normal lives within 5 to 7 days, driving within a week, not taking pain medication. It's very fast recovery and lets people stay out of the hospital, which is what we want and what they want as well.
Yeah. So less pain, shorter recovery.
Kind of like every good thing you could think about surgery, minimally invasive surgery allows us to offer to people.
That's great.
Mm-hmm.
That's great. So what is the survival rate of uterine cancer?
I think for all of these cancers, the earlier we catch them, the better. Mm-hmm. And so for endometrial cancer specifically, if we catch it and do surgery and we do a good job doing the surgery, you have about a 90% survival rate. And survival is like no cancer after 5 years. Always there's going to be a few people who get unlucky and have that come back. But even then, this type of cancer is very treatable when it comes back the first time. So again, endometrial cancer is a good cancer if you get the short straw of having to have a cancer.
Okay. All right, let's talk about cervical cancer. I understand this is considered the most preventable gynecologic cancer. It's the slowest moving too, right?
It is. Cervical cancer is very tricky in that it takes years to decades to like fully form and people have symptoms. And so people have had kind of irregularities for many years and just kind of like written it off because most of our cervical cancer patients are late 20s, early 30s. They're having babies, they're getting married, they're, in the best years of their lives and they don't want to go see a doctor and have a pelvic exam for some spotting that maybe happened once or twice a month. Mm-hmm. So cervical cancer, when we catch it early, is curable.
Okay.
With the surgery, which again is a common theme. The unfortunate thing about cervical cancer is that if we don't catch it early, then it is not impossible to treat, but does need a little bit more thought put behind it and a little bit more commitment from the patients, just because the treatment to provide a cure is a lot more work.
Sure,
Mm-hmm.
sure. But it has a screening test.
It does. And I think, I've never had a pelvic exam, thank goodness, but I am heard that they are super uncomfortable. They're awkward. Like you meet a stranger for the first time and then do a very, personal exam. But pap smears are the best way for us to screen for and prevent the development of cervical cancer. And again, there's not a lot of things in medicine that we can say, if you have this, we can prevent something else from happening. A pap smear is one of those things that we can say does that.
Okay. All right, let's talk about ovarian cancer. Now, this cancer has a very low early detection rate.
It does. Whereas we can screen for cervical cancer and find it early. Ovary cancer, there's no screening test for. So there's no blood work. There's no picture. There's no anything we can do in a normal person and to say you're at a higher risk for ovary cancer. In patients that have a genetic condition or a genetic concern, there are screening tools, but we know that those patients are higher risk. So the screening tools may work a little bit better. But for just a normal person, our screening tests, we've actually learned hurt people because we end up doing surgery they don't need. We end up giving them treatment they don't need. And so ovary cancer is diagnosed based on symptoms.
Okay. So what are the symptoms of ovarian cancer?
Honestly, no one really knows. There's not like a hallmark symptom. A lot of times people will say they're vague. So they're bloating, nausea, maybe some hot flashes, maybe some vaginal spotting, things that people who get ovary cancer, so like a postmenopausal female, are going through anyways. You know, a lot of the symptoms that walking up the stairs I developed, and I'm like, oh my God, do I have ovary cancer? And it's tricky because it's vague. And people usually come to us with very, very severe symptoms because the other tiny symptoms were ignored for such a long time, which is really unfortunate about ovary cancer.
Yeah, and the symptoms of cervical cancer and uterine cancer.
Yes, ma'am.
Bleeding, right?
Bleeding. People see it and they're like, this is not normal. It's like bleeding kind of ruins someone's day. Like they're out at Target and they're like, oh crap, this is not great. Ovary cancer, people are like, oh, I'm just nauseous after I eat. Maybe it's some heartburn. And then they have heartburn for 5 or 10 years and then it turns out to actually be ovary cancer.
Wow. Okay. So what then are the treatments for ovarian cancer and what's the survival rate?
So I think the earlier we catch these, the better your survival is. So if it's early stage ovary cancer, again, we can do surgery and then say you have a super high, like 80 to 85% cure rate. When patients present to us though, they very rarely have early stage ovary cancer. They're usually at least stage 3. And so for the cancers we treat, they only go up to 4. So when we see most people, they're on kind of the other end of the hill as far as where their cancer is. That doesn't sound super hopeful, but because we deal with this type of cancer frequently, we know how to aggressively treat it when we see it and provide honestly pretty good outcomes. So when someone comes in and they have symptoms and a diagnosis, our first option is to hopefully do surgery. So this is a big incision. We can't do this minimally invasive. And we take out everything we see that has cancer on it. So your uterus, your cervix, both your tubes, your ovaries, sometimes a piece of your intestine, sometimes your spleen, your liver. That's why we do all this extra training and know all of these other subspecialists so that we can get all the cancer out and then start chemotherapy with a kind of a good clean slate.
Okay, well that makes sense. Vaginal and vulvar cancer. Now this one's pretty rare, huh?
It is. Fortunately, it's pretty rare. I'd say vaginal cancer is one of the rarest cancers just in general. And so a lot of times when someone has vaginal cancer, they really probably have cervical cancer that's spread or vulvar cancer that's spread. But there are some people that do have the true vaginal cancer. Vulvar cancer, again, is HPV mediated. So it's due to the HPV virus. So again, vaccination is one of the most important things you can do for your children to prevent them from getting this type of cancer. But it is a little bit better than ovary cancer because people have symptoms from vulvar cancer. So they'll say, I've had itching, I've had bleeding, I've had pain, I've had a lump that won't go away and has gotten bigger. I think a typical patient has been treated for like multiple yeast infections, multiple vaginal infections, and it just hasn't gotten better. And then they finally went to an OBGYN and had an exam and they saw this lump, this bump, and then they end up seeing us.
So what is the survival rate then?
Again, if we catch it early on and can do surgery and cut it out, we can cure people. So early stage, curable, people live great, normal, long lives. Advanced stage vulvar cancer is still curable. It's just, again, much more time intensive. The treatments are a lot more aggressive, and it's a lot more work the further that the vulvar cancer has spread. So again, doing your exams, getting vaccinated are the best things to not end up kind of in that boat. But if you do find yourself in that boat, it's not kind of a death sentence.
Yeah.
We see this frequently. We know how to treat it. We're here to help.
You know, we've been talking about all the different cancers. There's a lot of different strains of HPV, correct?
There are.
And not all of them lead to cancer.
They don't. They do not. The vaccine treats the strains that most commonly cause cancer.
Okay.
I think there's probably 100 different strains of HPV.
Wow.
And at some point I knew all of them, I swear. I swear. But at this point, we know that there's 2 of them, HPV 16 and HPV 18, that are the 2 bad players.
Okay.
And they're the ones that the vaccine specifically covers to prevent those precancerous cells from ever even forming.
Okay. Good to know. All right. So now I want you to talk a little bit about the team at the Cancer Institute, the Gynecologic Cancer team. You've got a very experienced team, don't you?
We do. I say if I knew another sports analogy, I would use it, but I don't.
That's okay.
Yeah, so we don't. I would say I'm the newest addition. I just finished fellowship, so I'm like licensed to treat, but we have people there who have just started treating cancer, all the way to people who've been there 50, 55 years. So I think I have seen and learned in like this new age of a new drug development every week and new surgical regimens, whereas we have other oncologists that have seen surgical, like minimally invasive surgery be developed and the first case is done. And so they know everything that's ever happened in GYN oncology. And so if you have a problem, one of the 4 of us has probably seen it or know how to treat it. And I think that's very unique here because you have a breadth of knowledge that is very useful for some of these types of cancers.
Okay, great to know. So before we go, I have to ask you, what is the most important thing you want our viewers or listeners to know? What's the most important thing they need to know about GYN cancer?
So I think there's 2. So
you can have 2.
I appreciate that. I think the first thing is postmenopausal bleeding. So bleeding after you've gone through menopause is never normal and should always be worked up. So don't say, oh, this happened once. You should never have bleeding after menopause without it being evaluated, because that's the easiest way for us to find a cancer early and treat it. And then the second thing is to be your own advocate. Medicine, there's 6 to 8 month waiting periods to see a lot of doctors. It's very easy to say, I'm just going to deal with this. I'm going to Google it, and Google said I was fine. But if you are having symptoms that don't go away or symptoms that continue to build on each other, go to someone and tell them, like, this isn't normal. This isn't my normal, because that's how we do find some of these cancers earlier on and can, provide curative treatment versus patients feeling like they don't have a voice or don't need to be seen. So recognize your body because you know it best, and be your own advocate so that we can see you if we do need to as early as possible.
All right. Excellent. Thank you so much for sharing all this information today. It was a lot, but I mean, it was necessary.
It is. I think GYN cancers no one wants to have to see a cancer doctor. No one is excited to come see me any time of the day. But I always say, as your cancer doctor, I'm your coach. We're going to get through this together. We're a team, and these cancers are treatable. So I am always excited to see someone to start on their journey and kind of see them through it and kind of be there with them for the rest of their lives.
And the survival rates are getting better and better.
Better and better every day, honestly. And that's not just me being cliche. Like, these new drugs are actually curing and keeping people cured, which is fantastic.
Excellent. Thank you so much.
Thanks for having me.
Well, that brings us to the end of this edition of Live Healthy West Virginia. If you're looking for more information about gynecologic cancer and other cancers, visit wvumedicine.org/cancer. And to find the latest episode and all episodes of Live Healthy West Virginia, visit wvmetronews.com/podcast or the Metro News TV app. I'm Mary Ravazio Menard, and on behalf of Dr. Barton and everyone at WVU Medicine, thanks for joining us.